Ok, ok. Prueba de audio número 1, 2, ¿sí? 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Ok, ok, ok. Prueba de audio número 1, 2, 3, 4, 5, 6, 7. Ok, ok.
Updates on childhood TB and lung health. Closer, is this better? Okay, cool, thanks James. Welcome everyone, welcome to today's session, and we're going to be talking about updates on childhood TB and lung health. And I would like to introduce our first speaker of the day, Sarah Perrier, and she's going to be presenting to us on the improved treatment outcomes in HIV positive adolescents with TB compared to adults in Kenya. Welcome. And Sarah, just before you start, sorry, I forgot to introduce myself. I'm Audrey Becker. I'm a neonatologist from Cape Town, Stellenbosch University, and I would just like to introduce you to my co-chair as well.
Yes. Good morning, everyone. My name is Ulo Benson from Kenya, a public health specialist, sitting in for Evelyn Kibuchi. Thank you.
All right, so I'm going to get us started. Can you guys hear me in the back? Okay. So my name is Sarah Perrier. I'm an infectious disease fellow at the University of California, San Francisco. The work I'm going to be presenting to you today that was sponsored through the Appiah-Bora Fellowship at the University of Washington and done in conjunction with my colleagues at the Kenya Ministry of Health and CDC Nairobi. So I'm going to be talking to you about improved TB treatment outcomes among HIV-positive adolescents versus adults in Kenya. So to start us off, just a little background in terms of why do we care about adolescents as a subgroup in terms of HIV-TB outcomes. So I think to talk about that first, we have to start with the HIV epidemic among adolescents. So among adolescents, since 2005, we've seen a 28% increase in the number of adolescents living with HIV. Since 2000, we've seen a 300% increase in AIDS-related deaths among adolescents. And within that, we see that sub-Saharan Africa has been disproportionately affected. So 85% of adolescents with HIV are in sub-Saharan Africa, and 50% of those are in just 6 countries, Kenya being among one of those. So that's ultimately culminated in that right now, HIV is the #1 cause of death among adolescents in sub-Saharan Africa and the #2 cause of death among adolescents worldwide. So then I think a fact that we're all pretty familiar with, that TB is the #1 cause of death among people living with HIV, kind of leads us to that natural inference that TB is probably the leading cause of death among these adolescents with HIV as well. So moving forward with that, it's going to be important as we're trying to get a hold of the HIV epidemic among adolescents to understand TB in that subgroup and understand what their outcomes are so that we can take those next steps from a programming standpoint and try and intervene to reduce negative outcomes among them. So what do we know right now about HIV-TB co-infection among adolescents? The answer is not a whole lot. So we have a few studies that show us, from a small study out of Botswana, showing us adolescents have higher loss to follow-up rates than adults. That loss to follow-up is augmented even further when they're HIV positive. We know that among MDR adolescents, they tend to have very high mortality. And we know from some studies out of South Africa that co-infected adolescents, again, tend to have really high loss to follow-up and high mortality rates. Other challenges that we know we face with adolescents is that they're in a really unique developmental stage. Adherence among them is very challenging. And one of the reasons we know so little is adolescent hasn't been very clearly defined. So the WHO defines adolescents as 10 to 19-year-olds. Throughout the literature, though, as we know, they've been intermittently 10 to 19, 12 to 18 older groups. And then the WHO reporting definitions right now break adolescents apart so that they get reported as pediatrics up to age 14 and then with young adults from age 15 to 24. So it's really been hard previously to tease out necessarily what's going on with the TB-HIV epidemic among adolescents as a distinct subgroup. So the purpose of this study was to try and describe and compare TB treatment outcomes among adolescents and compare them to adults within the context of Kenya. This was a retrospective cohort study. It utilized the Kenya's electronic case-based register. So this captures all registered TB cases in the country since 2012. The study spanned 2012 to 2015. And the analyses included standard statistics and then multinomial regression modeling in order to compare treatment outcomes and control for TB type, ART status, and a variety of other confounders. So this is just to give you an idea of the study flow, and I'm sorry if this is a little small. So going into that case-based register over the 4-year study period, Kenya had 362,000 cases of TB. So first we went in and took out the pediatric under 10s, and about 92.8% were over age 10. And then eliminating out the HIV positives, the HIV co-infection rate among TB cases in Kenya was about 35.2%. And then we broke that into our 2 study cohorts. Adults, those over age 20 and older, who accounted for about 95% of the cases, and then adolescents, those aged 10 to 19, which accounted for 5% of our cases. And just to comment on that, so one of the reasons that the adolescents represent such a small number is our HIV positivity rate among TB cases in adolescents is only about 17%, and part of that just has to do with their time at risk for acquiring HIV over their lifetime because it's been shorter. So in terms of our cohort characteristics, just to start us off, so our adolescents had a median age of 14, the adults had a median age of 36. The adolescents were predominantly female at 53.3%, whereas the adults were predominantly male at 51%. And then looking at them by ART status, really good ART uptake across the board, but slightly better in adolescents at 92.3% versus 89.9% in adults. And there was statistical significance between those in both groups. So then to really get to the heart of the matter with this, what did we see in terms of TB outcomes? So I want to step through this slide kind of piece by piece. So first off, looking at what our positive treatment outcomes were. So treatment success is a grouped variable looking at both cure and those who were recorded as completing their full treatment regimen. So we saw in our adolescents that they had an 84.3% rate of treatment success. Adults were slightly lower at 81%, giving an adjusted risk ratio of 1.04. While it's small, it was still significant. And then I think where we move on to the more interesting parts are, what about the negative treatment outcomes? So loss to follow-up is certainly what we worry about a lot with adolescents because they're so hard to retain in care. And we were actually surprised to find our adolescent loss to follow-up rate was 6.8% versus adults who were being lost to follow-up at a rate of 8.1%, giving an adjusted risk ratio of 0.85. Then in terms of death, the mortality among our adolescents was quite high at an absolute mortality rate of 8.6%. Adults' mortality rate was 10.4%, so the risk ratio of 0.8 in that case. And then looking at treatment failures, there was really no difference between the groups, though likely due to the very small numbers, with a treatment failure rate of 0.3% among our adolescents and 0.5% among adults. So in terms of what we found, so adolescents were more likely to be on ART. It was only a slight difference, but it's somewhat interesting because we typically think of the adolescents as being hard to get in care or being lost in between that pediatric and adult transition. So it's something that it's hard to explain just from the epi data, but it'll be something interesting to look into. We found that our adolescents have a decreased risk of loss to follow-up, which is counter to what we've seen in prior studies, and that they had a decreased risk of death compared to adults. Lastly, we saw that adolescents had increased risk of TB treatment success, so they were doing better in general, and that there was no difference in treatment failure between those groups. So from that, we could draw that our HIV-TB co-infected adolescents have improved treatment outcomes compared to adults, but I think what's still striking about it is their mortality rates are still, from an absolute standpoint, quite high. So you wouldn't expect an adolescent to be with HIV-TB co-infection to be dying at the same rate as an adult. So while comparing between the two of them, the absolute rate of 8.6 is still quite high in terms of mortality for adolescents who you would expect to have a little bit fewer comorbidities and just in general better outcomes. So just to acknowledge, this work was sponsored through the Afibora Fellowship at the University of Washington. I just want to thank you all. Great.
Thank you very much. I just want to ask, open the floor to questions. I think we have time for 1 or 2 questions. Oh.
Thank you very much. My name is Maureen Sekade, and I'm based at the National TB Program in Uganda. So just looking at the adverse outcomes, could it be that these adolescents are enrolled in peer support groups or adolescent-friendly services that actually improve their treatment outcomes?
Yeah.
Is that one of the interventions that is applied in Kenya? Thank you.
So I think that's an excellent point that you bring up about why they may be doing better. So one of the challenges of this data, I think, is that we can't separate out our adolescents who are perinatally infected versus those who are sexually infected, and then we don't know how long they've been in care based on this epi data necessarily. So there is a good chance that a decent proportion of them have been in HIV care for a long time. And then within Kenya, within our HIV care cohorts, they have really well-established national guidelines that enforce having adolescent-specific care at all of the HIV clinics. And so I do think it'll be interesting to explore and see if that's one of the reasons that adolescents are doing better, is because they're already enrolled in HIV care and getting adolescent-specific services at the clinic level.
We have time for 2 more questions.
Thanks, Sarah. Great study, really interesting data. I just wondered if you could comment on the quality of the data. I just find the results quite surprising. And obviously you're making your conclusions on data that's coming from a database, essentially. I find the results somewhat hard to believe, but I hope they're true.
Yeah. So in terms of the
let's just take one more, then you can handle them.
Just a quick one. Thank you very much. Obviously, 10 to 20 is a big age bracket. An 11-year-old is very different to an 18-year-old, and also a 21-year-old is very different to a 75-year-old. Are you able to do any more? I mean, you've got a big data set there. Are you able to do an analysis with any more granularity? Because there could be significant kind of confusions, and a lot of that mortality in the adults could be biased by much older people. Is there any way you can kind of give us a bit more information about the details within those 2 big buckets?
Yeah, absolutely. So to answer Andrew's question first in terms of quality, so the Kenya TB Register, in terms of treatment outcomes, is actually pretty complete, and there's data quality enforced both at the clinic level and then by the county level TB officers, where they do go in and do audits and review. Some portions of the database aren't that complete, but in terms of recording of treatment outcomes, it's pretty accurate, and in terms of their names. The one thing I will say is the recent TB prevalence survey certainly indicates to us that we're missing about 40% of cases in Kenya. So it's not necessarily a true reflection of what the TB burden is within the country. And the other thing the TB prevalence survey showed us is that the group that has the highest rates is 15 to 34-year-olds. So I think there is a chance that we're missing a good proportion of the adolescent burden. Then to answer your question in terms of breaking it down from a granularity perspective, yes, certainly it's one of the advantages of having this case disaggregated, and I kind of simplified it for the version of this. So we've looked at it, breaking it down and comparing pediatrics versus doing young adolescents as 10 to 14, and then older adolescents as 15 to 19, and then also breaking out young adults as 20 to 24. And I think the main difference we see is, and I think it probably reflects their mode of HIV acquisition, is that the 15 to 19-year-olds do worse in terms of mortality than the 10 to 14-year-olds. But the loss to follow-up rates were actually higher in the 10 to 14-year-old group. The comparisons to adults, when you break down the adolescents like that, still hold true. And then when you break out young adults as 20 to 24, they do the worst. I've done it as like a full disaggregated thing, and the other interesting trend that emerges from it is the mortality rates in like over 60s is incredibly high, like 30%.
Thank you very much,
Thanks.
Sarah. I'm going to go ahead and introduce, and I'm going to be talking about childhood MDR in the European Union and European Economic Area. Thank you.
Good morning. So I'll take you from Africa, from Kenya to the European Union and the European Economic Area. And that's a number of 31 countries, and together they have a population about a little bit more than 500 million. Let me see, yeah. And in this area, we know that of all TB cases, children are about 4.2% of the total. We also know that globally it's estimated that multi-drug resistant TB among children is about 2.4%, but we had not studied that in the European Union. So what I'm going to present to you is a study on MDR-TB in the European Union. Our objectives were therefore to quantify the burden of MDR-TB in the European Union. We also wanted to identify factors that are associated with MDR-TB in children. And we will assess whether there were gaps in diagnosis and gaps in treatment of MDR-TB in children. For this, we used the European Union TB surveillance database, and that database started in 1995, and by now it includes about 1.5 million TB cases, and it's case-based. For this specific analysis, we took the data from 2007 to 2015, and that's because for that period, the drug susceptibility testing results are available. And we were able to include data from 26 of the 31 countries, and that is because Croatia and Liechtenstein did not report for the whole period that we included in the study, and France, Italy, and Spain do not report case-based drug susceptibility data. We have a number of variables in our data set, and what we used was of course age. We used gender, drug resistance, pattern, origin, site of TB disease, TB treatment history, and TB treatment outcomes. The age group that was included is pediatric TB, so those below 15 years of age. And for treatment outcome, we used two different definitions. For the cases that were drug susceptible or at least not MDR-TB, we looked at treatment outcome 12 months after a start of treatment. And for those who are MDR-TB, we looked at treatment outcome 24 months after start of treatment. And we used these data for descriptive analysis and also for logistic regression analysis. If we then look at the data that we have in our data set of, we had about 19,000 pediatric TB cases. As of course is often seen, only 22% were laboratory confirmed. And of those that were laboratory confirmed, we had DST results for 82% of the cases. So if you look at those 82%, the 3,378 cases, then we see that 88% of those were drug susceptible, fully drug sensitive. 7% were monoresistant, 2% polyresistant, 3% MDR-TB, and 0.2% were diagnosed with XDR-TB. So in total, a little bit less than 100 MDR and XDR-TB cases were identified in the data set. If we then look where these cases were diagnosed, then we see 4 countries that had reported most of the MDR-TB cases in children, and those were the United Kingdom, Germany, Romania, and Sweden. Of course, United Kingdom and Germany are also 2 of the biggest countries in the EU, so therefore they probably diagnose most MDR-TB cases in children. Romania is the country that has most TB cases. It reports about 1/4 of all TB cases in the European Union, and therefore they might report most MDR-TB cases in children. And Sweden has quite a lot of migrant TB cases in migrants, and as we will later see, migration is related to MDR-TB. So then what the second objective was to look at factors that were associated with MDR-TB in children. Of course, since this is an EU-based database, we don't have a lot of variables in our data set, but if we look at those that we have and that might be of relevance, we see that 2 were associated with MDR-TB in children, and those are origin, so cases of foreign origin had more frequent MDR-TB. And foreign origin is defined as having a nationality or being born in a country other than the country that's reporting the case. And the other variable that was associated with MDR-TB in children was previous treatment, and that's of course what we expect. Next, we looked at treatment outcome, and in this slide I show you both the results of the non-MDR-TB cases in children and the MDR-TB cases in children. As you see, treatment success rates are quite high, much higher than what we find in adults, where we only find 40% treatment success rate in MDR-TB cases. So the non-MDR-TB cases got to almost 84% treatment success, and the MDR-TB cases were at 78%. The main difference you see is in the percentage still on treatment, which is higher in the MDR-TB pediatric cases. Then, looking at gaps in diagnosis, you already saw part of these data, but I want to reiterate them. So of all the cases that we have in the database, 22% were bacteriologically confirmed. This is low, but we all know that it's really challenging to get a bacteriological confirmation of TB in a child. And the 22% is actually quite similar to what has been reported from the United States and from Australia. So even though it's low, it's not exceptionally low if you compare it to other areas. Of those who were bacteriologically confirmed, 82% had DST results. And of course, being in the European Union, we really want to get that to 100%. So even though we only miss the results of 18% of the cases, it should go to 100%. So there is a gap, we would say, there in diagnosing drug-resistant TB. Given this, laboratory diagnosis is a challenge, and we would like to know both the bacteriological result and especially the DST result to be able to direct the treatment as good as we can. So in conclusion, the burden of MDR-TB in children in the European Union is rather low, with 3.2%. We would like to see improvements in laboratory diagnosis, and we hope that new methods will come out that will help us to confirm TB in children and also get a DST result for children to direct the treatment. And we found two factors that were associated with MDR-TB in children, and those were being previously treated, which is rather obvious, I would say, but also foreign origin. So for people practicing in the European Union, that might give them higher, if they find foreign origin or previously treated children with TB, they might have a higher suspicion of that being MDR-TB. I want to acknowledge all the people that work with us and that provide us with the data, and I'm not going to go through the list, but you can read them yourselves. Thank you for your attention.
Thank you very much. Are there any questions for Marika?
Thanks very much. Really interesting. Are you able to say anything about the 80% of children with clinically diagnosed TB who were treated for MDR-TB from their treatment regimens? Because obviously a lot of children who don't have a confirmed diagnosis of MDR-TB are treated for MDR-TB based on a contact history or failing therapy. And it would be really interesting to look at the outcomes for those children and the presentations of those children as well. And presumably you've got treatment regimens for these children. Are you able to say anything about those?
The 18, or do you mean the ones that were not bacteriologically confirmed, or the one without DST?
The ones who weren't bacteriologically confirmed.
Okay, well, but in any case, our data set does not include treatment regimens. So we just know that they were treated, and we know the treatment outcome, but we have no information in the database about whether they were treated with an MDR-TB regimen or with a regimen for drug-susceptible TB. So since this is a high-level database, we don't have it. For that, you would need to go to the member state, to the country level.
Thank you very much. We're going to continue to the next speaker, and I would like to introduce Paolo Denti. He's from Cape Town, and he's going to be presenting on the pharmacokinetics of rifampicin in children, evaluating the new WHO guidelines. Welcome, Paolo.
Okay, thanks a lot, Adri, for the introduction. I have two disclosures. The first one is that I forgot once again the slide saying that I have no conflict of interest. And the second disclosure is that I'm a pharmacokinetics of rifampicin in children. So, a little background about rifampicin. Everybody knows what it is. I'll tell you something about the pharmacokinetics. So, it metabolized to diacetyl rifampicin, which has lower activity. and the drug is excreted in the bile, both rifampicin and its metabolite. It displays saturable pharmacokinetics, which means that if you double the dose, you don't get double the exposure, you get more than twice. And this is interesting because from recent studies from the Panacea Consortium, there is interest in increasing the dose because this has been shown to be beneficial. So first adults will be increased, but eventually also children will receive a dose increase. So where does this study come from? Well, historically, children have been shown to have lower exposures than in adults. So here we have a plot with area under the curve, which is basically concentration of the drugs. Here we have the levels achieved in adults, and in children dosed with the WHO old guidelines, the exposure was much, much lower. So adults received 10 milligram per kilograms, and after receiving these results, WHO decided to up that dose from 10 milligram to 15 milligram per kilogram. This is not really a surprise for several reasons, including the fact that in an old review from the 70s, they were already advocating for raising the dose in children to 15 milligrams, but better late than never. The other reason for this, and I'm gonna try to explain it, is that to somebody working in pharmacokinetics, this is really not a surprise. And the reason for that is that it's expected that if you dose children at the same milligram per kilograms as adults, they're going to achieve lower exposures. So I'm going to try to elucidate this with a plot. So if you have a reference exposure in your adult, 70 kilogram, what happens just because of geometry almost, is that children that have a, as you move on the scale of weight, since clearance per kilogram is higher in smaller individuals, you're going to achieve lower exposure to the point that when you get around 10, 12 kilogram child, if you dose the same milligram per kilograms, you're going to achieve almost 30% less of the concentrations. The story is a bit more complicated because in younger children, there is another phenomenon which is known as maturation, meaning that those children are not just small adults, but also immature adults. So their metabolic pathways are not 100% efficient, and this is going to reverse the trend, meaning that for their size, those children are going to clear less, so they will need slightly less drug. And this starts mattering around 2 years of age. So what we normally do in pharmacokinetics, we first adjust for the effect of weight, and then we try to elucidate the effect of maturation, because that's very different for different drugs, because the pathways are very different. So when we try to characterize this maturation, what we do is we try to estimate how the metabolic pathways are mature using post-menstrual age, because obviously at birth, children already have, neonates already have a certain clearance. So what we try to do is try to describe this maturation until the point when the only factor is weight. So if you are going to keep one sentence from all this presentation, is that children are small adults, but babies or infants are immature children. So these are the two effects that need to be kept into account. So this was the study design. So we recruited 170 children in 3 sites, 2 in South Africa and 1 in Malawi. And they were dosed according to the new WHO guidelines, 50 milligram per kilograms within this range. We collected several samples. Here we have the characteristics. I also have a plot. Most notably, the children were not dosed using FDCs because the fixed dose combination tablets were not available for the new recommended doses. So individual formulations for each of the drugs were used, and in this case, 2 liquid formulations were used. One was a powder to be reconstituted in water, and then a suspension was also used. Both the formulations were certified and supposedly bioequivalent. The youngest children in the study were dosed using an esogastric tube. Here I have a colorful plot of weight versus age and sites. So here's the distribution of age and weight across sites. You can see that we had a whole lot of children in the youngest age range, and this is because, as you've seen, that's where most of the excitement happens, and that's where you need most data. Most of these children down here were also dosed using an esogastric tube. So some early results were showing, especially in the cohort of youngest children, very, very low exposures for rifampicin. And when looking further into that, it was identified that one of the 2 formulations that was used in the study had a much, much lower bioavailability. And very interestingly, the content of the formulation was the one declared on the label. If you run it through a mass spec, the amount of rifampicin was the right one. but the formulation was not getting absorbed. So those children had about 30% the exposure of the children on the other formulation, which was a major effect. So after these preliminary results, we decided to look at the data in a more nerdy way, using pharmacokinetic modeling, and I'm gonna take you through it. So when using a model, what you try to do is describe what happens when the children take the drug. So we had a rifampicin dose, rifampicin concentration, and desacetyl rifampicin concentrations. So the drug gets absorbed, and after a bit of a delay, it appears in the GI tract, from which it gets absorbed into our blood, but before it goes through the liver. And in the liver, we were able to separate the two metabolic pathways, which is the excretion of rifampicin in the bile and the deacetylation, which makes the metabolite. What we could then characterize is that both these pathways, the excretion of rifampicin and the excretion of desacetyl rifampicin, were saturable and jointly so, meaning that both these compounds compete for the same transporters. And since there is a limited amount of transporters where there's too much of them, the system saturates and you get your nonlinearity. In this case, the nonlinearity was not very visible, but it was important to include it here because we plan to use this model to now escalate the dose once it will be finally escalated in adults, hopefully. So these are the main effects that we found in the model. So unsurprisingly, we found that allometric scaling, the adjustment for body weight that I described before, worked quite well to adjust for body size. On top of that, we could characterize the maturation of clearance, and I have a plot about that. And another effect that we found was after adjusting for the formulation, the faulty formulation that had a much lower bioavailability, we found a further effect of age on bioavailability. Bioavailability is the amount of drug that gets absorbed and gets into the bloodstream. And this point was a bit tricky to evaluate, and I'll take you through it as well. So this colorful plot is another very nerdy plot. It's called the visual predictive check. It tells us whether our model is actually predicting the data. So the dots are the actual observed concentrations. The lines are a summary of those concentrations, median, 10th, and 90th percentile. The shaded areas is where our model expects that data to fall. So as long as the line falls within their shaded area, we believe our model is reasonable. So what can we see here? We have on this line the concentrations versus time for rifampicin, here for the metabolite, and here it's split by the bad formulation and good formulation. So you can see that this is a log plot, so all the children receiving the bad formulation had much, much lower exposure than the children receiving the good formulation. And I have a zoom here of the children receiving the good formulation. So here I split children by age, less than 1 and more than 1. You can see that the exposures are slightly lower in this category, in this group of children. This is logged, so there is a bit of a difference. So trying to summarize the effects that I discussed, the first one was the effect of maturation. We were able to identify two separate maturations for the metabolism pathway, the esterase that makes the metabolite, and the excretion. We found that the excretion matures a bit later than the metabolism. And this has some consequences that the children in this age will have slightly more metabolite and they won't be able to get rid of it at the same speed because the excretion is not as fast, although the concentrations were not worrisome. And this is the other effect that I wanted to talk to you about, which is the effect of age on bioavailability, which seems to explain why the children in the youngest age range had lower bioavailability. So here we have a plot of the variability in bioavailability after adjusting for all the other factors that I talked to you about. And we can see that it remains fairly constant until around 2.5, 3 years of age, after which the concentrations go down. The problem is to tease out why these concentrations go down, because lots of the children with the blue dots are the ones that receive the drug with the nasogastric tube. And presumably at home, children will not have a nasogastric tube. So it was hard for us to impute whether the cause for this decrease was indeed the nasogastric tube. And lots of those children also received the faulty formulation, which is this icon over here. So there were lots of concomitant factors at that time. What are the reasons for these low concentrations then? Is it the nasogastric tube? Is it age per se? Is it the formulation? Rifampicin is not well absorbed when the pH in the stomach is high, and small children are reported to have higher than normal pHs in the stomach. So that could be a good explanation. And this could also play a role with the formulation that did contain rifampicin, yet it did not dissolve properly. In any case, we ascribed this effect to age per se, and then based on that, we simulated what exposures the children are expected to achieve with the new WHO guidelines. So here we have a plot of maximum concentration that is achieved. So this is the maximum concentration and the spread in the various weight bands. So you can see that all these children received a certain amount, 4 tablets, 3 tablets, 2 tablets, 1 tablet. So we can see that the exposures are much better than they were with the old guidelines, but the children in this weight band still have lower concentrations. When looking at the plot for AUC, which is the main parameter used for efficacy, we still observe that some of these children are underexposed, but the exposures are much better than they were with the old guidelines. So wrapping up, the exposure is improved with the new WHO guidelines, but in younger children, for unclear reasons, the concentrations are still low, and we need to investigate whether this was due to NGT or to the formulation, or if it's just an effect that is there in young children. And the other take-home message is that it's very, very important to look at the bioequivalence of formulations, because this formulation was approved, yet it didn't perform as well, and it's unclear whether this was because it was in children or if there are any other complicating factors. And here are the acknowledgements, all the people that helped, the patients in the study, and the funders. And I'm here for questions. Thank you.
Unfortunately, running out of time, so I'm going to ask people to hold their questions and ask you afterwards.
Okay, cool.
And then we're going to move on to the next speaker. If I can ask Hamish Graham to please come up. He's going to be discussing hypoxemia and pulse oximetry and oxygen in Nigerian hospitals. Thank you.
Focus away from childhood TB for a moment and talk about oxygen. We'll have slides shortly. Oxygen is something that you all know very well. We're all breathing it here right at the moment. We need it for life, and even just a few minutes without oxygen would be very compromising. But you might be wondering why we're talking about oxygen now. Oxygen's not new, it's not particularly innovative. Oxygen as a therapy has been around for over 100 years. We know oxygen can be life-saving for young children with pneumonia. Studies have shown that oxygen as part of therapy can reduce case fatality rates in hospital by about 1/3, by about 35%. And for someone like this child, who's come in very sick with pneumonia, almost unconscious, drowsy, severe increased work of breathing. I'm not sure if you can see the number down on the screen there, but that's showing her SpO2, her blood oxygen level, which is 49%. This is her just a couple of minutes later. She's still obviously very sick, still breathing very fast, but SpO2 now 96% just on 0.5 litres of oxygen, half a litre of low-flow oxygen. So oxygen can be really life-saving for children like this. Doesn't mean that it's oxygen alone. Obviously, she needs antibiotics, she needs other treatment, and some children, low-flow oxygen will not be enough. They will need more higher support. But for many children like this, a little bit of oxygen can be life-saving. And the sad fact is that the vast majority of children like this in low and middle income countries around the world will not get oxygen. Oxygen will not be available for whatever reason. So for that reason, we're doing a large field trial in 2 countries, in Nigeria and Papua New Guinea. The goal of it is to make oxygen available for every child that needs it. We've got about 30 small hospitals in Papua New Guinea and 12 hospitals in Nigeria, and for the purpose of today, I'm going to focus on some of the preliminary results coming out of Nigeria. This is an ongoing trial with continuing data collection until the end of the year, but I want to highlight a few things that are coming out of our 12 hospitals in Nigeria. Now, our project is based on learnings from what other projects have done over recent years, and the background behind it is that we want to focus not just on oxygen access, but also on oxygen use. Oxygen access in our context means introducing equipment. For us, we're using oxygen concentrators, pulse oximeters. It means enabling technicians to be able to maintain, repair these equipment, keep them running for hopefully 5 or 10 years. It means building maintenance repair structures so that this intended maintenance and repair will actually get done. And it means making oxygen affordable both to patients and to hospitals. And this is a really big thing in Nigeria, where healthcare is essentially fee-for-service, user pay. And traditionally, oxygen has been exceptionally expensive to hospitals. Many of our hospitals were thousands of dollars in debt to oxygen companies. We're fighting every month just to get a small supply of oxygen. And this cost was being passed on to patients who would end up with extraordinary debts at the end of even short stays because of the cost of oxygen therapy. The other side that we're focusing is on oxygen use. And this is recognising that many hospitals have some sort of oxygen supply, but it's not used very effectively and it doesn't get to the children that need it. So this is about training healthcare workers, about equipping them with things like pulse oximeters so they can accurately determine who needs oxygen. And it's also about creating an environment where it's easy to give children oxygen to do the right thing every time. And we do this largely through multidisciplinary quality improvement teams. And to give you a bit of a glimpse of what that looks like in some of our Nigerian hospitals, you'll see some of our quality improvement team up the top left. So that involves nurses, technicians, doctors and administrators. You'll see some of the equipment here, including oxygen concentrator. That box on the wall enables us to give oxygen from 1 concentrator to up to 5 patients. Guidelines on the wall, you'll see training happening down the bottom, both for the technicians and for the nurses. And you'll see our installation crew putting in tubing, which enables oxygen to go directly from a concentrator to 5 patients without disconnecting, reconnecting, moving anything around. So to quickly just highlight a few of our results. So firstly, I want to just show you some of the hypoxemia results. So this is preliminary data, still got a lot more data coming in. What we're seeing is for all children under 15 years, hypoxemia prevalence is around 14%, but it's higher in younger age groups. So you can see in the neonates, it's 21%, in up to 1-year-olds, 15%, and in older children, around 8%. This is reasonably comparable with data from other countries, and it reflects the high burden of hypoxemia. And this is not just pneumonia, but this is all comers to hospital. The other thing that you can see here is hypoxemia is a big predictor of death. And in fact, across all age groups, hypoxemia was a greater and more accurate predictor of death than any other clinical sign. So not only is it common, but it's also a very good predictor of death. These are sick children. As you'd expect, it varies by condition. Now, I've just highlighted pneumonia and malaria here, so you can see among pneumonia, about 1/4 of pneumonia admissions were hypoxemic. But even in malaria, which you might not traditionally associate with hypoxemia, 8% of malaria admissions were hypoxemic. And when you look at the most severe cohort, so the cohort that are showing signs of WHO emergency signs, that's even higher, almost half of pneumonia patients and about 20% of malaria patients. In neonates, I mentioned that the hypoxemia overall is a bit higher, and in small preterm neonates it's slightly higher again, about 1/4 of patients, and it varies again by diagnosis. So 2 of the most common diagnoses we were seeing was sepsis and birth asphyxia, and you can see hypoxemia prevalence of around 20% and almost 1/3 of babies with birth asphyxia, perhaps not surprisingly. So that's the population we're dealing with. So how have we gone in introducing pulse oximetry and oxygen? So this is a graph just showing examples from a couple of hospitals in terms of pulse oximetry use. So our goal was to have every child admitted to hospital, every neonate admitted to hospital, to have pulse oximetry done on admission and then regularly during admission. You can see before we started, pulse oximetry was essentially not used at all in any of our hospitals. we introduced the pulse oximetry in around October, November 2015, and you can see a steady increase. Now that grey line that you can see is the average overall, our 12 hospitals, but I've just put in bars for 2 hospitals, the blue and the orange hospitals, just to give you an idea of, it varies between different hospitals, but all of our hospitals showed significant improvement, getting up very close to our target of 100%. So that's pulse oximetry use. What about actual oxygen use? So this is looking at appropriate oxygen use. So this is looking at the proportion of children with hypoxemia who received oxygen on admission. You can see that before we got involved, oxygen was being used, and a proportion of children, of hypoxemic children, were already getting oxygen. And somewhat similar to the pulse oximetry use, this has increased over time. A couple of interesting things come out of this. All the hospitals got set up with pulse oximetry at the same time in October, November 2015. But all the rest of the equipment, the concentrators, the improved oxygen source, the tubing and everything, that actually came later. But what we're seeing here is that there is already an improvement in the way oxygen is being used, even without giving them a better oxygen source. So you can see that for the blue hospital, but even more spectacularly for the orange hospital, which only got set up with the full oxygen equipment after all this data, and they'd already achieved 90% coverage of hypoxemic children receiving oxygen, which I think is a really big lesson for us when we're thinking about oxygen access. We really have to think about how oxygen is being used, not just putting more equipment, putting more oxygen sources into hospitals. We also had a bit of a look at what was it that helped pulse oximetry and oxygen be taken up by hospitals. And a few things came out: changing attitude, the way that we taught, and the idea of carrying people along. And I'm out of time now, but we'll be continuing data collection through to the end of this year, and hopefully next year I'll have some more fuller results, including some impact results to share with you. Thank you.
Since we run out of time, we'll not take any questions, but if we have time at the end, the speakers will still be here for questions. I would like to invite our 5th speaker, and that is Manette.
Good morning, everyone. And I would like to thank to the chairman and the organizer who gave me the opportunity today to present about the feasibility, safety, and the tolerability of nasopharyngeal spirit and the string test for the diagnosis of tuberculosis on expert in HIV-infected children. So as you may know that the microbiological diagnosis for TB in children is challenging due to the paucibacillary nature of TB in childhood, and also due to the difficulty to perform the respiratory sample. So the diagnostic performance is depend on both the bacteriological test and also the different specimen collection method. And the WHO has recommended to use GeneXpert for the diagnosis of childhood TB, and it is now more available in different settings. But there are still persistent the issue with the feasibility of the specimen collection method. So one of the objectives in the Pointer study is to evaluate this feasibility, safety, and the tolerability of the alternative specimen collection method. The study was implemented in 4 countries, 2 in Africa, 2 in Asia, in the pediatric HIV site and 1 respiratory disease. We included children, HIV-infected children, aged from 0 to 13 years old, suspected of TB, and we do this alternative specimen collection method. So after the informed consent signed by the parent or the guardian, the child will be undergo different specimen collection according to the age category. And you can see that there was mentioned in red the alternative sample collection. So nasopharyngeal spirit and stool sample was performed in all children together with the standard sample, gastric aspirate or sputum. And string test was done in children more than 4 years. And none of the nurses that were participate in the study, they have experience to do this sample before, so we trained them. And all the sample was sent for expert and culture. We also train the nurse to collect the adverse event and also to evaluate the discomfort, distress, and pain using the different evaluation tool. The Wong-Baker face scale. What is the pointer? The Wong-Baker face scale is for the children to do their auto-evaluation, and the visual analog scale is for the parent to evaluate the child perception. And the behavioral scale or the FLAG scale is for the nurse to evaluate the face, the leg, the activity, the cry, and the consolarity of the child. Here is the baseline characteristic. We include 438 children in the study, and 426 children has at least one sample performed. And there was no difference between gender, and the median age was 7.2 years old, and more than 50% of children was enrolled in Asia country, and more than 50% of children they are malnourished with the weight for age that score minus 2.5 HD. So as you can see the feasibility, you can see here that the feasibility of the nasopharyngeal spread and the stool sample has higher feasibility, similar to the gastric aspirate. However, string test has a little bit lower feasibility. If you look the result on expert, you can see that the 3 specimens that has higher detection on expert are the nasopharyngeal aspirate, the sputum sample, the nasopharyngeal aspirate, and the stool sample. If we look at the safety of the gastric aspirate, nasopharyngeal aspirate, and string test, you can see that the string test is safer than the gastric aspirate and nasopharyngeal aspirate, in which 24% of gastric aspirate and 35% of nasopharyngeal aspirate has at least one adverse event recorded, and only 7.6 on the string test. And there was different, significant difference in terms of local trauma or no bleeding on the nasopharyngeal aspirate compared to the gastric aspirate, and no difference between the 3 methods in terms of vomiting. If we compare the tolerabilities of the 3 methods using the evaluation tool that they was evaluated, this is the children, this is the parent and the nurse. You can see that string test is better tolerable than the gastric aspirate and nasopharyngeal aspirate. So nasopharyngeal aspirate feasibility was no different between country and also no different between the age group category, as all country and all age group they has higher feasibility. But however, the tolerabilities are different between country and also different between age group. That all children is better tolerable than the young children. And the feasibility and the tolerability of the string test, there was different between country. It was difficult to implement the string test in Vietnam, and the tolerabilities are also different between country. The country that has the poor tolerability has also the lower feasibility. And this feasibility of string test seems to be better in older children, and it's consistent with also is better the feasibility in this age group. So in conclusion, the string test seems to be good tolerability, but they are poor feasibility, and also lower detection than gastric aspirate and nasopharyngeal aspirate on the kidney spurt. So the nasopharyngeal aspirate that has a high yield expert on expert than gastric aspirate and string test, but the tolerability it seems to be similar or a little bit worse than the gastric aspirate. And as you know that nasopharyngeal aspirate is technical requirement, we need to provide training and supervision in order to reduce the adverse event. So we think that the combination of nasopharyngeal aspirate and stool sample could be used to decentralize for the diagnosis of childhood tuberculosis in the ambulatory facility. And I would like to acknowledge to all patients and family who participate in the study and all the team from the 4 countries. Thank you.
Thank you very much. We have time for 1 or 2 questions. Any questions at the back? Please raise your hand so that the volunteer can see you from the back.
Hello. I'm curious why there was such a big difference between Vietnam and the other countries in the tolerability of the string test. Could you comment on that?
Yes, there are 2 main issues related to this feasibility in Vietnam. First, when we train the nurse in Vietnam, the perception of the nurse for the string test is like invasion method for them. So for the nurse, they are reluctant to perform the string test to the kid. One. And the second issue that in Vietnam, the children they are used to use the pediatric formulation, the drug. So when we ask them to swallow the capsule, because the string test, I don't know if you know the string test, the capsule is like the amoxicillin, the capsule. So it was difficult for the children in Vietnam to swallow the capsule as they used to swallow syrup formulation. That was the main reason that they are low in Vietnam compared to other countries.
Okay. Anyone quick one? I think that is it. Thank you very much. Yeah, I'd like to welcome our next speaker, Benkin again.
My name is Sarah Benke-Nugent. I'm in the Department of Global Health at the University of Washington. Today I'm going to talk about lung function in early treated HIV-infected children, and I'd like to thank the conference organizers for giving me the opportunity to talk to you today. I also want to ask for your patience. My research actually focuses on neurodevelopment in HIV-infected children. We had an opportunity to delve into this very interesting question of lung function in early treated children as a result of this work. So as I struggle to tackle a rather complex issue in front of a room of experts, I'll ask for your patience. Let's see. I have no conflicts of interest to disclose. So UNAIDS has estimated that there are 1.8 million HIV-infected children alive today, the vast majority of which reside in sub-Saharan Africa. UNAIDS also estimates that only 1 in 2 of those children are receiving antiretroviral therapy. There's an emerging data that suggests that perinatally HIV-infected children and adolescents with delayed access to HIV diagnosis and treatment have alarmingly high frequency of chronic lung disease. In Zimbabwe and in Kenya, 2 cross-sectional studies have shown that over 80% of children and adolescents had either chronic respiratory symptoms, abnormal chest imaging, abnormal spirometry, few of which were reversible, few of which had bronchodilator reversibility. Focusing more on lung function abnormalities, in Zimbabwe and Kenya, Malawi, and South Africa, it's been estimated that 24 to 45% of children have some form of lung function abnormality. In comparison to reference population data, less than half of which was reversible with bronchodilator. And in Zimbabwe, in a comparison of perinatally HIV-infected children to HIV-uninfected children suggested that 24 versus 12% of children had lung function abnormalities, 1/3 of which had bronchodilator reversibility. So it's easy to imagine that uncontrolled HIV infection early in life might have a very grave impact on developing lungs. HIV is associated with chronic undernutrition, recurrent infections, high viremia, poor immune status, and chronic inflammation. And what we really wondered is, for children with access to early HIV treatment initiated during infancy, might they be protected from some of these detrimental impacts? And if we could look closely at cofactors, early cofactors for lung function later in life, could we begin to piece apart or identify children who might have higher risk of poor lung function in spite of early treatment? So to reiterate, our objective was to determine the prevalence and cofactors for abnormal lung function in early treated HIV-infected children. So spirometry is a relatively cost-effective way to assess lung function. It's one component of pulmonary function tests that measures, one, how much air can be forcibly exhaled, or forced vital capacity, or FVC, and how fast the air moves, or forced expiratory volume in 1 second, or FEV1. It can be used to detect some chronic lung diseases. It can be diagnostic for airflow obstruction, such as chronic obstructive pulmonary disease or asthma, and it can also be suggestive for restrictive deficits, such as pulmonary fibrosis. So for our study, we identified and enrolled perinatally HIV-infected children during their infancy and followed them through school age. HIV-infected infants were identified in Nairobi, Kenya between 2007 and 2009. All of the infants in this study initiated ART by 12 months of age. And although our field team worked very hard to try to identify children in maternal child health centers, the reality is that the majority of these children were identified in hospital. Through their early life, children attended monthly visits and provided detailed data on growth and comorbidities. They also provided quarterly blood specimens for measurement of HIV RNA and CD4. At 6 to 8 years later, 40 children were able to undergo lung function tests. We collaborated with Dr. Rashida Farrand, who provided just a wealth of knowledge and expertise and support as we conducted this study. The spirometry was performed by a highly skilled nurse who performed the spirometry in accordance with international guidelines. Experts adjudicated the traces, and only high-quality traces were utilized in analysis. So we used 2012 reference equations to calculate z-scores for FEV1, FVC, and the z-score for FEV1 to FVC. We used linear regression to identify cofactors for poor lung function outcomes. So this slide summarizes some characteristics of the HIV-infected infants before they started treatment. They were a median 5 months of age. They were quite immunosuppressed when they were identified as having HIV. Their median CD4 percentage was 19. Their median weight for age z-score was minus 1.33, and their median log plasma virus level was 6.6 log 10 copies per mil. Now at school age, again, we perform spirometry on these children. We have data for 40 children. They were a mean of 8.7 years at the time of spirometry, and we found that 13% had a lung function abnormality. 8% had obstruction, and 5% had evidence of restriction, again, based on their reduced FVC. Now the mean FEV1 and the mean z-score for FVC were actually just slightly above the average for the reference population. So again, we wanted to look at early cofactors and try to understand what might be associated with poor lung function in spite of early treatment in these children. We looked at characteristics that were present before starting ART, and then we also looked at their early indicators of how well they responded to HIV treatment. So before starting ART, infants who were undernourished had lower lung function outcomes on the order of a magnitude of approaching a full standard deviation below average compared to the reference population. And interestingly, we also found that infants who lacked viral suppression during the first 6 months on treatment also had significantly lower scores for FVC. So our study has a number of unique strengths. To my knowledge, this is a unique report of lung function in perinatally HIV-infected children with early treatment, although I know that the South African share cohort has also collected this data, and we'll be very interested to see that as well and compare and contrast. these children had long-term follow-up, which afforded analysis of early life cofactors. It's important to note that our study was limited by the fact that we did not assess bronchodilator reversibility, and also importantly, we did not compare to an age-matched cohort of HIV uninfected children. So to summarize, we found that a substantial proportion of HIV-infected early treated children, 13%, had evidence of abnormal lung function. At the same time, these early treated children appear to have a lower prevalence of abnormal lung function compared with some of the late treated cohorts that I mentioned earlier in the talk. And then finally, we found that children with poor early viral response to treatment, as well as children who had undernutrition before starting ART, had compromised lung function in spite of early treatment. So at this point, I'd like to thank many people, my mentors and collaborators at the University of Washington. Very importantly, I'd like to thank our Kenyan colleagues. It's been a real privilege to work alongside them these past 10 years. I would also really like to thank Dr. Rashida Farrand, Sarah Rylance, and Jamie Rylance, who provided us with quite a bit of technical support in conducting the spirometry, the infants, children, and caregivers who participated in our studies, and our funders, the NIH and CFAR. Thank you.
Thank you very much. We have time for some questions. If you have questions, please raise your hand. Questions for the presenter?
Yes.
There's one question.
Thank you for the nice presentation. I have two questions. The first one is justification of having a low FVC of 5% in school-age children.
I'm sorry, do we have
a justification of finding 5% of low FVC, the restrictions of this?
Yeah, justification meaning the quality of the...
I mean, is it related to anything to find...
Well, so from the logistic regression, or the linear regression analysis, it suggested that the infants with poor response to ART had a lower FVC, suggesting that potentially infants with lower FVC might have some risk of those restrictive deficits. But it's really slicey and dicey to try to compare those infants who lacked viral suppression with the very few who had evidence of restrictive lung function abnormalities. So I think we are limited by our cohort size and stretching too far in making that assessment.
Thank you. The next question is, can you tell us about your experience on performing the spirometry in those children? Because for me, I was working on a study with adults, and it was really difficult to perform the spirometry test.
Super hard.
Yes.
Yeah, it was super hard. We tried for probably more than 2 years to get this done. We sought training from an organization called Spirometry 360. They provided us with a lot of training materials, which was great. But the reality is that we just couldn't get it done until we had a very highly skilled person working in the clinic with our nurses. And at the end of the day, this data was actually performed by that nurse who came to us from Zimbabwe and works for Dr. Farrand. What really sealed the deal in terms of training the team was just having that nurse there and understanding that as long as you have the sort of the technical capacity to review the curves as you're collecting the data, that greatly improves the chances of acquiring high quality traces. Yeah, it's a good question.
Thank you very much. One round of applause for the presenter. After this presentation, we'll open the floor for questions. Even for the earlier presenters, we have a bit of time. We'll be able to handle that.
So my name's Leo, and I'm going to present some data on contact tracing in Uganda. So tuberculosis is a leading cause of global childhood mortality, and most of these deaths occur among undiagnosed cases. But despite that, interventions to find these undiagnosed cases are not widely implemented, especially in low-income settings. Household child contact tracing has been widely recommended by tuberculosis experts and global health organizations because of the high yield for infection and for disease. Despite these wide recommendations, implementation fidelity of child contact tracing has been suboptimal, especially in sub-Saharan Africa and other low-income settings. Partly to deal with this, the World Health Organization came out with a pragmatic screening approach in 2006 and updated this in 2012. The idea was to find symptomatic children that were child contacts and HIV-infected children, and to prioritize this group as a way to make child contact tracing more efficient. Also, this algorithm wouldn't use microbiological testing, chest radiography. Clinicians could be included, but evaluating symptoms does not necessarily, they don't necessarily need to be included. And so it's a pragmatic approach in these settings where uptake of child contact tracing is poor. And so this is a figure in one of the many studies that present this algorithm. Basically, you have a child contact up top, and then you stratify by age, below 5 and above 5, and HIV status, and you screen symptomatic contacts. Those that have disease, you treat. Those that don't, you can follow up with IPT or not. So this algorithm has not been prospectively evaluated very often. I think there's one prospective cohort study that has evaluated this algorithm and found it highly effective. In the context of a large prospectively followed cohort of child contacts, we attempted to estimate the concordance between the WHO pragmatic guideline with secondary TB, so coprevalent and incident TB, and also to calculate how many of the total tuberculosis caseload would be detected if the pragmatic algorithm was implemented for tuberculosis at baseline and for follow-up. And child contacts were defined as below 16 years of age. So this is it's a little cut off, but I think you can basically see everything. This is the Coempe Community Health Study. It's a large household contact study in Kampala, Uganda. A very long-term study from 1995 to 2008. This has a very basic study design for household contact tracing. So index cases were recruited, households were visited, household contacts were recruited, tuberculous skin testing and active TB was assessed at baseline, and then incident TB was followed up over 24 months. Coprevalent disease was defined as at 3 months from baseline or before. Innocent disease or any disease 2 years or before. Sorry, I don't know if you can see this too well, but I'm going to walk you through it. There were 857 index cases, 3,048 total household contacts. This includes of any age. We excluded adult contacts because they did not pertain to our research question. There were 1,718 child contacts below 16. 126 had coprevalent disease, so 7.3%, very high percentage. And incident disease was 1.5%, so there's 24 incident cases diagnosed. The tuberculosis-related symptoms included in the algorithm that we had access to also were chronic cough, poor appetite, weight loss, fever, night sweats, and hemoptysis, I'm going to say it wrong. And HIV seropositivity was also included in the algorithm, as previously shown in the other figure. So there's 1,718 contacts. We evaluated the WHO pragmatic guidelines based on that. Median age was 7 years old. Most of the kids were 5 to 15, but we had almost 600 that were below 5. Almost 80% were BCG vaccinated. Really high HIV seropositivity, especially among index cases, 44%, but almost 4% among child contacts, which is also fairly high. The most common tuberculosis-related symptom was chronic cough. It was 15% of child contacts had that. Okay, so let me see. So this stratifies by coprevalent and incident disease and by every symptom included. So you can see here all child contacts, around 7% coprevalent disease, 1.5% incident disease, as I said before. But if among child contacts that had any symptoms, you can see coprevalent disease skyrockets up and reaches above 30% among some of these symptoms, so very high. Not all, you have to know that the sample for some of these is not the whole sample, obviously. 105 had weight loss, 54 had HIV seropositivity, and so on. But if a contact had any one of these symptoms, they were included in the algorithm. We also found a dose response with the number of symptoms, which makes sense. So you can see here, this is those with 0 symptoms had 3% coprevalent disease, 17% if they had 1 symptom, and this increased over time. It's important to mention that the number of children with increasing symptoms decreases over time. So we, of course, shouldn't just screen those with 6 symptoms, even though they have high prevalence. We should, the idea is to screen all of these children. A similar relationship was with incident disease, although we had low power from this one. So 0.7 had incident disease among those with 0 symptoms, and it's increased among 1, 2, and 3 symptoms. So 11% of those with 2 symptoms had incident disease, so very high. And important here is the percent of all cases detected. So among those with children with 1 or more symptoms, so that would be included in the algorithm, that's detected almost 70% of all pediatric tuberculosis cases in the sample. So that was 87 out of 124 pediatric cases. And this, around 63% of incident cases were detected. So 15 out of the 24 incident cases were detected by those with 1 or more symptom. Really quick, I'm gonna walk you through this quickly. This is the entire algorithm. So those with symptomatic or HIV seropositivity was 23% of the sample. 22% had coprevalent disease versus 3% among those asymptomatic and HIV seronegative. Also, there's high incident disease, around 5% compared to below 1% among those not included. When we stratified by age, we found similar results. And this is a really busy slide, but I'm going to focus it for you. So for those younger than 5 years of age, coprevalent disease among symptomatics was 32%, so very high. Among asymptomatics, coprevalent disease was 6%, so very high, also very high, but very clear difference. Among those above 5 years age, we found also lower rates, but similar difference. So 9% coprevalent disease among symptomatics or HIV seropositive, and around 1.8% among those asymptomatic. For incident disease, we also found big differences, 4% among those included in their algorithm below 5, less than 1% not included in the algorithm. Same thing for those above 5 years old. So 6% versus 0.7, so big differences here. We wanted to also, really quickly, because I'm out of time, I'm gonna do this. We also wanted to see if this was applicable, if we could try to test if this was applicable in high and low income settings. So we basically took HIV out of the algorithm, and we just used tuberculosis-related symptoms, and then we stratified by HIV status of the contact. So among child contacts that were HIV seropositive, there's 54 of them. We stratified by symptomatic or not. 50% of symptomatic HIV positive children had coprevalent disease, so huge rates. 7% or 6.5% among asymptomatic, so also very high rates, but clear differences. And here among HIV seronegative, we also found big differences, 23% versus 3.5%. For incident disease, there's 8% versus 3.5%. We had really low samples of incident disease because we're stratifying multiple times. So this was not statistically significant, but this is somewhat of a difference. And 5% versus 0.9%, which was statistically significant. So just to conclude, so the WHO's pragmatic guidelines detected approximately 70% of coprevalent disease and 63% of incident disease among child contacts, while only screening around 20% of all of contacts. So we think this guideline may be a useful tool in high HIV burden settings, such as sub-Saharan Africa, where child contact tracing is not currently being performed. We also think it's important not to just use this algorithm as a solution, a complete solution to the problem. We think we don't want this to discourage buildup of laboratory infrastructure for microbiological testing. We think that's also very important. So. There's more people on this project than I could possibly name, and I'm over time anyway, but I just want to acknowledge them. I'm just the person presenting this. They did all the work. So thank you.
Thank you very much. Are there any questions for Leo?
Cool. Thanks.
Then we actually have 5 minutes left of the session, so I was just wondering, are there any questions for any of the presenters? Well, then I'm actually going to thank everyone for their wonderful presentations. Thanks for attending, and thanks for the variety of topics regarding pediatric TB that we've heard about today. Thank you.